sit is under the clinical pillar under academics and research. In the HSE Library Service, we have a leadership team. I report into Dr. Anna Therese, and I have 3 area library managers, each with a remit for 2 of the new regions each, Benary, Tony and Brendan. So just for any of you who's not already a member of the HSE Library Service, you can go to hselibrary.ie and you can log in and register there and get set up with access. It's primarily for HSE staff, but we also have collaborative agreements in place with funded agencies that work in Section 38s and some 39s. So some of the value added services as a library service that we provide is an evidence service. There are 4 levels of searches provided by a team of librarians with an awful lot of experience. We support our own HSE staff, the HICWA Health Technology Assessment Team, and the National Cancer Control Programme in particular. So these are the types of searches, the levels that we do. There's a quick search, a standard one, a comprehensive one, and then a summary of evidence. So of the kind of service that we provide. Another value-added services is to provide ISBN supply for published HSE reports and to help people keep up to date, because there's so much information out there with research bulletins and electronic table of contents. Again, you can get that from our website. We provide training as well. We have an information skills team and they provide online training. You can book that at hselibrary.ie. We have a training calendar to see what's coming up. We also have local training available in each of the library sites that we have around the country. And these are the library sites in the HSE, primarily based in hospitals, but we have quite a broad network of good library staffed libraries around the country. There are our general contact details. We have one telephone number for the whole service, 0818 100 900 if you need to get in touch with us. Our generic email is hselibrary@hse.ie, and we also have an artificial intelligence virtual assistant called Llama, Library Ask Me Anything, available when we're not 24/7. So just in the area of global health, in 2015, as you're probably all aware, all countries in the United Nations adopted the 2030 Agenda for Sustainable Development. It sets out 17 goals, which include 169 targets. Ireland is a member of the UN since 1955. So there's wide-ranging and ambitious goals to ensure healthy lives and promote well-being for all at all ages. So it's a cross-cutting initiative, and progress in its implementation contributes to progress towards other goals, and action on other goals in turn contribute to attaining goal 3. And most of the goals have some direct health targets, and all of them have indicators by which progress can be measured. So in terms of resources for global health, I just put together a short list. There's African journals online, there's PubMed, which is freely available. Embase, everyone has access to that through the HSE Library Service. The WHO obviously has a Global Health Observatory with an awful lot of data and information on it. There's Global Health, which is a public health database. There's Google Scholar, which is free. Cochrane Library is free to everyone in the whole island of Ireland. Web of Science, you can gain access through ourselves, and there's Global Index Medicus, and EBSCO is a publisher that has several databases. So that's just a snapshot of what we have available, but I'm pleased to tell you that our library team are working on a subject guide for global health, and that will be available in the coming weeks. And at least that'll be a place for people to go to with authoritative information, which will help. So that's more or less the end of my presentation. But I'd like to introduce our next speaker, Dr. David Weeklim. He has worked in international and global health since 1988. Before joining the HSE in 2007, he worked for 18 years on improving health in developing countries. He worked also as a health advisor with Irish Aid, the government overseas aid programme. David is now a consultant here in public health medicine, based in Dr. Stevens, same as myself. And he works as program lead for HSE Global Health Programme. So thank you very much, David, for agreeing to speak, and we really look forward to hearing from you.
Yeah, thank you very much. I'm delighted to be able to participate today. And I would like, if I could, maybe to try and share my screen. And if that doesn't work, then perhaps you could share it from you. It'll be a little bit easier if I'm able to work from my own slides. But I'm having some technical difficulties with Teams and
No
not
worries.
new.
You can try there, David, and if not, I have the slides ready to go.
Yeah, thanks. Yeah, it's not coming up for me. So I think the best thing is, yeah, not to delay, but if you could share the slides, please, and then I'll, yeah,
Okay.
get you to take me
Hopefully
through
you can see my screen sharing. It's like I'm the same. I can't get into the app today either, so maybe it's a national thing. Okay. Can you see your slides? Can anybody see the slides
Not
showing?
yet.
Not yet. Okay. Okay.
Your screen is sharing, Natasha, just not the slide.
Oh, is it just my screen? It's not the slides. Okay. Okay.
That's looking good.
Okay.
Great, thank you. So, would you like to move on to the next
Yep.
slide?
There we go.
Great. So I'm going to talk for about 20 minutes. I'm going to say a little bit about the Global Health Programme in the HSE, a bit about how we work, how we go about our work, and what we do. And then I'll come on towards the end just to say a little bit about opportunities for library staff and staff in general in global health. And that will kind of tie in with, I think, the things that Aoife shared in her introduction. Next, please. So we're a small team in the Global Health Programme. There's 4 kind of permanent staff, myself and three management staff, and then we also have a registrar in public health medicine with us on rotation each 6 months. So while a small team, we have a lot of reach because we work very widely across the health service with different people across the services and with other external organisations. Next, please. Now, Aoife showed a little bit the structure of the HSE, which is changing, and where the library services fit into that. Now, Global Health Programme, it sits under access and integration, and that's currently in the new structure where we sit. And what's, I think, significant in relation to the governance is that we have some important relationships for our work. One is with Irish Aid, and that's in Department of Foreign Affairs. That's the Irish Government Aid Programme. And we have a memorandum of understanding between the HSE and the Irish Aid Programme, which aligns our work with Ireland's international development policy. We have some also important relationships with other organisations that are founded on agreements or memorandum of understanding. So that's the case with the countries we partner with, and there's 5 countries in Africa, and I'll talk more about them. But also with some other external organisations. We have agreements with the Irish Global Health Network and with the Royal College of Physicians, with whom we work in collaboration, and we're involved with others as well. Next, please. So the next couple of slides are really to talk about why we do what we do. And the first question is well, what do we mean by global health, and what is it for the HSE? And typically, in my experience, a lot of people will, when you talk about global health, they think of Africa, they think of poor countries and how we can help them. And I'm always sort of saying it's not about geography, it's about really how we understand health. And today we just have to see health in a global way. Health is global. We can't really make a distinction between, well, this is Irish health and that's Sudanese health. It's the nature of health today is that the health issues that we deal with and that we respond to in our health services are shared issues, common issues across countries. We're interconnected in health. And so it's in our interest and in everybody's interest to work together. And a lot of these trends are very obvious. We've had the COVID pandemic, migration, climate change. You can think of all of these issues that are very global. Next, please. And when I'm talking to people about then why the HSE gets involved, if you say, well, that might be all well and good, but is it the HSE's role to be involved in global health? Well, I think there's 3 reasons. And it's about our mandate as HSE, which is to provide quality health and social care services for the population of Ireland. If health is global, we need to learn from other countries. We need to engage with other countries on issues that we're all working on. And then what about then? Do we have responsibility for other countries? Well, we do, and Aoife referred to the Sustainable Development Goals. This is a commitment of our country, of our government, and the HSE is a partner in the government's international development policy. And if you read the policy, A Better World, you see the HSE is explicitly mentioned as a partner in that. And so we have a responsibility, and apart from even what's in the policies, I think we also have a moral responsibility because of global health inequities. We're part of a very unequal world, and we can play a role in addressing that. And after that, we have resources to share. They're not money, but we have lots of expertise and institutional knowledge, particularly that we can share with others. And the third reason for being involved is that many of the issues are issues shared across countries that need a collective response, like pandemics, like migration, like climate change. And we can't address these in isolation from each other, so we need to work together. Next, please. So that's the basis of our strategy in the Global Health Programme. And part of the strategy of our focus is both outward looking with other countries, and particularly low and middle income countries, improving health there, but also it's about improving health and healthcare here in Ireland. And there's 4 areas that cover what we do. Partnerships is the foundation of everything we do. We work with other countries, low and middle income countries, but it's all about partnerships. It's about the relationship. We don't go in just to implement projects. We build long-term relationships through which we can then work together to improve health and healthcare. And that's mainly with government, but also with other healthcare providers and non-governmental organizations. We share expertise. That's our main resource to share, is our individual expertise, but also institutional knowledge and learning. And we do that through our relationships with partners, to peer-to-peer learning, education, sharing of knowledge and skills, and so on. And also here, the other resource that we have to share is equipment. We've lots of equipment that's replaced in the health service, and that can be available to give to other countries. Networking is an important part of what we do. Ireland is a small country. We link up with other partners, with universities, with training institutions, with non-governmental organizations. And working together, we can be much more effective, especially with a small team, with a small program. And then the last area is about thinking of us in the HSE, about how we respond to health being global. It's to be an organization that's more global oriented, so that we are learning all the time from the global context, and we're thinking of health in Ireland in a more global way. Next. So the work that we are mainly involved in is most of our time is working with 5 countries in Africa, where we have relationships with the governments, with the ministries of health, agreements to work with them. We're there because they've invited us, and when we engage with them, we respond to needs that they identify, areas where they would like us to collaborate with them to improve health in those countries. And while the focus is typically more on the needs in those countries, we're always saying, well, if this is mutual, these partnerships are about two-way learning, and we're always keen to learn from them as well. So Mozambique, Tanzania, and Ethiopia, they're 3 countries where Ireland is working through the AID program, and there's embassies there, and we work closely with the embassies. And then Zambia and Sudan. Next. So what are we trying to do with these countries? And partnerships are a lot about you work with partners because you have something in common. You have a shared objective, a shared interest. And what our shared interest is in health is this goal of universal health coverage. I mean, often in Ireland, we talk about universal health care. Universal health coverage is a somewhat stronger term because it's emphasizing access. And this is a term in the Sustainable Development Goals, the target of universal health coverage. This is what we all want to achieve, that everybody everywhere gets access to the healthcare they need without experiencing financial hardship. And nowadays, in most countries, even in poorer countries, most people have access to healthcare. So it's about who doesn't have access. And in the Sustainable Development Goal motto is leave no one behind. That's what we're interested in. And this applies in Ireland as it does in other countries. Who's left behind? How do we reach this goal of where everybody gets the care they need? Next. So what part of our initial work then when we work with countries is to try and understand understand the context. What are the gaps and needs so that we can engage effectively? And this is just an example, one of the frameworks we look at with universal health coverage. If you look at the small box there on the left, thinking of, well, if universal health coverage is our aim, well, who's not covered? Who's missed out? So often people who are marginalized because of geography, because of gender, because of ethnicity, disease, and so on, many reasons. And then, well, which services are people not getting? So we can focus on some of those areas, the gaps. Where is the care not being provided? And then the financial side as well. Which services are people not getting because of financial implications? And then on the right, it just adds the other dimension of quality of care. People may be getting the care, but are they not getting the care they need really because the quality is poor and they don't get good outcomes? So we need to understand when we work with countries, part of our initial work is to understand the context well so that any input we bring is helpful. And that's quite challenging when we work a long distance. It's really important to take time to understand, learn about the country and understand the context. Next one. And then what we're working together on is improving health systems. And we say that, we want to improve health care so people get good health outcomes. But if you want to bring about sustainable improvements in healthcare, you need to build the systems to deliver care. This is no different whether it's Ireland or another country. And most countries are familiar with the WHO building blocks of health systems. So we work there. You see the areas there on the left of the slide. Areas like the health workforce, strengthening the health workforce. That's a huge part of what we do. It's not about us going in and providing care. If we can strengthen their capacity or help strengthen capacity to deliver care, that's a big achievement. You'll see their information and research. So this is something that will be of interest to those of you working in libraries and in information services. And then at the bottom, service delivery. So just one part of the system is the service delivery. And there's a lot we can do to work with partners to improve service delivery, even when resources are very scarce, which is usually the case. Next, please. And an area that a lot of our work is in improving quality of care. And there's two reasons, right, for this. One is the need. And often people think, well, people die in poor countries because they don't get access to care. That's true. More people die in low and middle income countries who have access to care, but because they die because the care was poor quality, it was unsafe. And so this huge impact can be achieved by improving quality of care. But from our perspective in Ireland as a partner, we don't have money to give. But we can share knowledge and experience around improving quality of care and provide training and so on. And even with the resources that our partners have, there can be really effective improvement and improve outcomes. Next, please. So I'll come on to that a little bit more in a minute with an example. And then another area, key area, is strengthening the health workforce. And this is at different levels. I think a big thing is about working with countries for them to develop their own national training programs. So rather than focus on training doctors or nurses or other health professionals, is help them to build up their own training program so that they can train their people. And when they do that, then people don't migrate. Brain drain happens because people leave to get trained in other countries and they don't go back. But if they can develop good quality training programs, that much better chance they will stay and provide care locally. And then we also do provide some training and we work with others across the health service, providing training in different technical areas in partner countries. And sometimes people come to Ireland for training. And we're linked in closely, for instance, with the National Doctors Training and Planning and the HSE. There's a program, the International Medical Graduate Training Initiative, under which doctors come from Sudan and Pakistan to train in Ireland for 2 years, and then they go back to their country. And this is part of Ireland's commitment. You see on the right on the slide, the WHO Global Code of Practice on the international recruitment of health personnel. We are reliant on health professionals from other countries for our own service. How can we do that in a way that doesn't weaken the health systems in the countries they're coming from because we're taking away their health professionals? So we try and have programs to try and support those countries. And this is in line with the WHO strategy, global strategy for human resources for health. This is a very big issue for our work because we are part of the whole challenge in global health is the workforce. There's a shortage of health workers globally, and there's a lot of migration to richer countries like Ireland. And so we need to work together with other countries on solutions for that. Next one, please. So our work then, working in these partnerships with different countries, and some of them we run ourselves and some we facilitate other parts of the health service to engage in, which might be like hospital twinnings, or it might be with training organizations or public health departments. It could be libraries, working in these partnerships with counterparts. And so different technical areas, and I mentioned quality improvement. And just one example from one of the hospitals we work with in Mozambique, in both Ethiopia and Mozambique, a lot of our work is with hospitals. They've asked us to help improve quality of care there. As a result of training, one hospital that when they started off, they were experiencing, they said 11 deaths per month on the medical ward because of poor quality of care, and how they're going to address that. And that was back in 2016, and then training in 2017, that reduced to 58 deaths in a year. And then by 2019, that was 8 deaths in a year. That didn't require extra resources. It was about learning how to use the resources it got in a better way. And there's many examples from different hospitals that can show those kind of results. And then we work with others who are involved in technical areas. I'll give an example of cancer care. This is Dr. Trish Scanlon, who's an Irish pediatrician in Tanzania, working to develop cancer services very successfully. That's not our initiative, but in small ways we can support that through funding, through sending equipment, through other kind of expert support. And then technical areas like mental health, some very, very important areas of healthcare need in low and middle income countries, where we work together on different types of partnerships in areas like dementia, that's in Bangladesh, mental health recovery in India, mental health well-being of health workers in Ethiopia. So different collaborations. Next, please. And some of these smaller collaborations are facilitated through a program that we run called the ESTER program, ESTER Ireland. And this is about twinning partnerships where institutions in Ireland partner with or twin with a counterpart in a low and middle income country. Often hospitals, but it might be a GP practice, it might be a public health department, it could be a training organization, it could be a university. And what we do in our program is we provide small grants to help these partnerships develop. These are very small, 8,000 to 10,000 euros a year. But to build a relationship, we really believe the relationship is so important, to develop a relationship and then to do collaborative work. And many of these have been very successful across different countries in Africa and Asia, many thematic areas of need. Next. Then another area we've been, I suppose, drawn into more in recent years is responding to some of the humanitarian crises that have come up. COVID was a crisis that we got involved in, working on training programs, teaching with low and middle countries, and then donating several plane loads of equipment to India and Nepal. More recently, Ukraine, and we've been donating medical equipment there and supporting some technical projects. So it's not something we particularly choose to do, and we're not at that type. We're not a humanitarian organization, but there are times when we have resources and capacity and expertise that we can share with other countries. So I expect with Gaza, we're likely to get drawn into that more and be providing support. We're providing support to Sudan in their crisis at the moment. So donating medical equipment has become a significant part more of our program. We have for many years been donating used equipment to Zambia, and we're moving to a situation now where, working together with the National Equipment Replacement Program, we're planning that every item of equipment that's replaced, rather than discard it, which isn't good for the climate anyway, why not see if some of that equipment could be used well in another setting? And if it's suitable, then we're happy to make that available. And we've quite a bit of experience now what's the right equipment and how to send it out in a way that's going to be useful. Next one. So this is all very, very, it's very good to be able to contribute to health in other countries, but we want to bring that learning back to our own health service. And I think there's a lot of we can do here that we've not yet done. There's so much we can learn from countries that have very scarce resources. They're very, very good at knowing how to use resources well. They've often much stronger primary care-based systems than we have, often much better at involving the community and people in their own healthcare, better involvement sometimes with voluntary organizations, much more outcome-based, not just about activities, but seeing how resources can achieve outcomes. A lot we can learn, and we're looking at ways in which we can share that learning between our work with countries in Africa and back here. Next one. And another thing we're working on is trying to build up global health knowledge and capacity in Ireland. I think everyone in Ireland needs to have global health skills, because health is global. So what does that look like, and how do we develop it? And I've been leading a project with the Forum of Postgraduate Training, medical training bodies, and we recently developed a curriculum and e-learning module. And now that all doctors going through specialist training, global health is now become one of a core competence, that an area that they will learn. It's not about doctors being interested in health in other parts of the world. It's about working in Ireland. You need to be competent in global health, because that's the nature of health today. And we're very interested to develop that further, so that there's learning resource available for everyone working in the health service. in all areas of work. Next, please. So finally, just really to say a few words about, well, what about the libraries? Is there a role? And this was just for this particular meeting. And, you know, looking at what the library aims to do, it's providing an integrated and high quality national library service to ensure that the best possible evidence underpins patient care, decision making, education and research in the health service. Well, we need that in Ireland, but other countries do as well. So definitely this is something that would be of real interest if we could be also involved with other countries. And looking at the vision there that talks about at the end, for the benefit of all. Well, is that all in Ireland or is that all more widely? Well, I put it out there, maybe that's all everywhere because health is global. Maybe we need to think of all, because all is something we should be concerned about today. The next. And then the last slide is maybe going back to some things Aoife already said, well, what is it about that library services and people working in this area might be involved in? It's making better use of information and evidence. And when I go to countries in our partners in Africa, they're always talking about this. How can they get better information and evidence to inform their policy and practice? And often they talk about research, but it's not just about research. It's all areas of information and information literacy. And the idea that you know, how can we help increase the abilities and skills needed for identifying health information needs, accessing relevant health information from reliable health information resources, and using that information for sound health decisions for living healthier lives. Now, this applies at a citizen level, but it's at the level of the ministries and those planning health services, those running health services. How can they be better at that? And I just put down 4 things came to mind immediately: building skills in information literacy, providing access to e-resources on healthcare, supporting countries to search for evidence to inform health policies and practice, and facilitating sharing of learning between countries. And we might also add to that what Aoife talked about earlier is just is that having global health resources available to people in Ireland who are interested, that's another, I think, valuable area. I think there's huge scope, there's huge need, and I think I'd be very interested in having further discussions with people who are interested in this area as to how might we link up some of the skills and experience that we have in Ireland with matching that with needs with some partners that in other countries, and how that might work. I think there's plenty of scope there. So thank you very much for listening, and I'm very happy to take questions and look forward to the discussion.
Thank you, David. I'm just going to stop sharing now. And Seema, you might be able to start sharing.
Just while you're doing that, thanks so much, David. Lots of food for thought there. And I really like the reciprocal learning element in the partnership approach and how we can learn from others here in Ireland. I think that's really valuable. There's lots of scope for areas where we can definitely, as a library service, support some of the initiatives you're doing, and we'll definitely talk about that. So thank you for that. I'm going to introduce Dr. Seema Biswas. She's been an editor-in-chief of BMJ case reports for 14 years. She is also a general surgeon, and her research interests are surgery, trauma, global health, and medical education. You're very welcome, and thank you so much for joining us today.
Thank you so much for that kind invitation. Can everybody hear me all right? Lovely.
We can.
It's actually a great privilege to follow on from such a great talk by David. You'll forgive me if I echo some of the things he says. I want to take you through a cook's tour of what BMJ Case Reports does in global health. And I want very much to follow on from David in that global health is everywhere. So it very much applies to your own practice wherever you're working at the moment in different parts of Ireland, and also the partners that you work with overseas. And I would hope that on some of the manuscripts you might work on that I might get to see, that there's a mixed authorship of people based mainly in Ireland and people based with partners overseas, whether it's Bangladesh or Zambia or wherever it is you happen to be working. So I suppose the best place to start with is what is global health? And we've heard David already say this. It's very much about improving access to healthcare, but the healthcare that you do have access to needs to be of a decent quality if it's going to really have a lasting impact. And so we want everybody to have that access, and that's a challenge. And because it's a challenge, inevitably we face on where there is work of causes and where there are disparities. And so this very much dovetails with a lot of the points that that David made earlier. And our way of working with global health at BMJ case reports is for you, of course, to focus on the holistic care of the patient. So all of the story of the patient, how are you, rather than what is the problem that's made you come to my clinic today? How are you? So the holistic care of the patient. How a patient lives and grows, if you've heard Michael Marmot say it again and again and again, are the social determinants of health. And we'll look more closely at them in a moment. But it's all about where you live, how you live, what services are available to you, what opportunities there are available to you, how things are for your parents, the level of income, the level of education. And of course, it doesn't need to be repeated again and again, but education and health are determinants of each other, and they have a unique relationship in determining each other. Now, I want to talk a little bit about this interdisciplinary or multidisciplinary role in global health. Because as you saw from one of the slides that David presented, the people that you're going to have to work with to improve the healthcare of a population are not just going to be, well, your radiologist, your anaesthetist, your surgeon, and your physician. You're going to have to go outside of the building. So it will be the medical team, it will be the legal team, it will be the social workers, the local council, local schools, local sanitation services at a more national level. We as doctors and as clinicians, as nurses, occupational therapists and physiotherapists, we're going to have to work with much larger centres in order to make a difference, not just to communities, but hopefully I'll demonstrate within this presentation to make a difference to an individual patient. So if we look carefully at these social determinants of health, it's impossible, or it should be impossible, to take a clinical history from a patient and not be able to identify some of the social factors that are really affecting their health. That problem that you have to focus on in those 7 minutes is hugely impacted by social factors. Again, where you live, the amount of criminality in the neighborhood, whether there's a safe place to play or exercise, how much food costs. Unhealthy food tends to cost more than healthy food. Whether the stairs are working, whether the elevator's working, whether you can go up and down safely, whether you can mobilize, whether it's safe for you to leave your house, whether you can heat more than one room of your house. These winter pressures that everyone knows that people always ask in a medical history, but perhaps we need to focus more on them if we want to make our patients better now, but keep them healthy in the long term. And so I would encourage you to log on to the website when you can and look at our global health case reports. We've got case reports from all over the world. And I think what you'll find is you'll be surprised by the different types of subjects that come up across global health, where ultimately we're looking at not just the causes of disease, so the pathological factors in disease, but the causes of those causes. So how not having a decent place to live and being damp and cold all the time will make that community-acquired pneumonia never go away. You'll get better and then you'll get ill again. How doing heavy manual work, yes, I'll repair that hernia, but you will get that hernia back again because you have no choice but to work because this is your livelihood. So what a global health case report is a standard clinical case report, all the same clinical information, plus an analysis of those social determinants of health and the access you have to healthcare. And remember what we said, and I'm going to echo what David said. It's not just access to healthcare, it's access to decent quality, effective healthcare that treats the problem now and keeps you well after you've been discharged from hospital or a clinic or a GP surgery. And I've deliberately used an example today that focuses on a little girl who was born in Cambodia, who is born without her thyroid hormones. She has congenital hypothyroidism, congenital underactive thyroid. And as you know, that affects your cognition, your development, and has a massive impact on the person that you will become, whether you can live independently, whether you can make the most of the educational resources that are available to you. It has a massive impact on mental and physical development and disability. And if you look at our global health resources, you'll see that this is research that I did with a colleague in 2018. We have global health case reports from all over the world. And these global health case reports have since then trebled. So I do encourage you to go onto that archive. You'll see the themes that come up. We always discuss at least one or two social determinants of health. We focus very much on vulnerable populations. You'll see amongst our case reports, people affected by war, people who are refugees, and people right at home. So Global Health made local, people right at home who have problems accessing healthcare, or who have problems accessing disability services and rehabilitation services. So there, you'll be surprised by the range we have. We have a person who was a war journalist who, through literally a lifetime of occupational hazards, was never able to take care of his own healthcare. They're fascinating stories to read, but they really do bring home the fact that global health is truly global. It's everywhere. It's all of us. Now, again, just a quick reminder about the social determinants of health and access to healthcare. So it's a clinical case study, plus we want to analyse the determinants of the health, the causes of disease, and of course, problems in accessing healthcare that is of a decent quality. So once again, a plea to look at our resources, because the best way to write is to read. So read what we have on the website and avail yourself of the free courses that we have on global health. They're free. They are based on courses that I have taught at different universities and medical schools, but not just to medical students, also to social workers and allied health professionals. And one of the courses you'll see is it's a model that can be adapted really into any framework. And what we're saying is, after that first encounter with your patient, where you take your clinical history, whether you're in a clinic room, whether in the accident emergency department, whether you're in a GP surgery, get to know more about the patient and the social determinants of health by visiting them at home. And then after that, I'm on slide 12, Ali. After that visit to the patient at home, walk around the area, see those social determinants of health. Where is it that the children play? Where is it that they buy their groceries? How much do they cost? Where is the healthcare centre? Is it open during normal hours? Is it open when someone's actually finished work and that's the only chance they have to go to the GP surgery? So say 8 or 9 in the evening. And then continue those visits. We've recommended 6 visits, but each time you get to know more about the patient, you're walking around in the patient's shoes, you're trying to access healthcare in the way they're trying to access it. So you really see the patient's world, you see the context that the patient's in from their own point of view. And so if I go back to our standard clinical cases, all of you have heard this and seen this slide over and over again. What do we publish? We publish patient-centered manuscripts where there's something new to learn or information is presented in a new and memorable way. Very much bedside learning. We're very much focused on learning directly from the patient. What is a global health case report? It's exactly the same thing. It's the clinical case studies. It's slide 14. And we're adding to that the social determinants of health and access to healthcare. So next slide, what you'll see is the patient is the center of this learning. And then we want to understand their world. So what is their world? The social determinants of health, access to healthcare, walking around their environment, walking around where they live, going to the same clinic and supermarket and play area and their work that they go to, take the same bus that they take to, change buses 4 times if they change buses 4 times. and then how that fits into the rest of the world. Because as you'll see from the example that I'm about to present to you, what's happening in Cambodia is relevant to what's happening in India and Pakistan and Iran and Saudi Arabia and South Africa and Central Asia. And we have so much to learn and so much to apply from one country to another. Again, forgive me for echoing exactly what you've just heard in the first presentation. Now, what's unique about Global Health Case Reports and case reports from the BMJ is that we have a section dedicated for the patient to write in their own words. And whether they're native speakers of English or they prefer to dictate it and you write it down, we do want to hear what experience of making sense of the signs and symptoms, coming to terms with the fact that you're unwell, that you might need to see a doctor, that might cost a fortune. I'm sure many of you among the audience have heard of the expression crippling health expenses, out-of-pocket health expenses, or going into debt because you've had to borrow so much in order to access decent healthcare, or sometimes access healthcare that really isn't that good. But we need to know that. And if we don't know these problems exist, and if a wider audience doesn't know that these problems exist, then nothing can be done about them. And the reason why I think it helps to study global health one patient at a time is that these aren't problems that exist in the atmosphere. These are problems that affect an individual and their family. And health and ill health can radically change the trajectory of an individual and what's happening in that family. You can be crippled by health expenses. You can be physically crippled by disability if you can't deal with something quickly. Yesterday, the news stories were full of a member of parliament who had sepsis and had his limbs amputated. Now, in a different country, for that person to come back to Parliament and resume their work and reintegrate into society with effective prosthesis, that would just not be something that would be possible. So we want to hear about the patient's perspective, not 2 lines of "thank you very much for the doctors who saved my life." That's not the patient perspective. We want to hear, what was it like to have this disease, to go through your treatment, to live with the side effects, to have to go on to a longer course of treatment, to adapt to working. Perhaps some people have lost their job. I've worked in many countries where, as a result of my operating on somebody in the long course of their recovery, they've lost their jobs, and these men are not going to be re-employed in their 60s. Effectively, that episode of ill health has completely changed the direction of their life. So we want the patient perspective. Now, because we want the patient perspective, informed consent is hugely important. And so we insist that the most senior person who really has a good idea of what the real world and social media and publishing online means, when a patient's information is shared online, it's out there forever. Even if you were to contact me and ask me to remove a manuscript, and I would straight away, I could remove it from our website, but it would still be available on other news media websites, other people's social media feeds, because it's downloaded and it's republished and it's used but taken up by other non-medical media sometimes, and also other medical resources. Informed consent is hugely important. What goes hand in hand with informed consent is anonymizing patient information. We don't need to know exactly where someone's from. We don't want someone to be able to identify that patient. We don't want an already vulnerable individual to be made more vulnerable. And so it goes without saying that these manuscripts, these global health manuscripts, this clinical plus social determinants of health and access to healthcare, they're difficult to write. They're not typical case reports. They're more involved. And so there's a lot of back and forth between the editorial team and the authors. We get to know each other really quite well. Slide 18. So we encourage you, if you are writing these, to tick the little box that asks you whether you want to enter the global health competition. If you tick that box, then we're alerted to the fact that perhaps you want to join our editorial team for a short time, or some of our Global Health Associate editors never seem to want to leave. And it's an opportunity for you to get to know a little bit more about the editorial process, about medical writing, and also to work on little global health projects with us. So if you are interested, because you'll get to know us so well when you're writing these manuscripts, because they're revised again and again and again until we've really made sure that we've presented essential information without compromising any information about the patient or helping people to identify them. You'll see that. You'll know exactly what I mean if you read some of the manuscripts. You'll see just how vulnerable some of the patients are. For example, victims of domestic violence, people in places where there's enormous amount of structural violence and violence within communities. So please do have a look and think about joining our team. You'd be most welcome. Now, I'd like to draw your attention to an attachment that was shared with you earlier. If you have time to look at it now, then please do. Now, to make life a little easier, because we've got so little time, I highlighted sections of the manuscript, but to be honest, to do justice to the contents of the manuscript, I would have had to highlight every line, in which case you'd be looking at some kind of psychedelic image of manuscript that published on it, highlighted many different colors. Now, if you hold it up and you look at the manuscript that's in front of you, why publish this case? It's a case of a little girl who was born in Cambodia without thyroid hormones. So as you know, people can have adult hyperthyroidism, an underactive or an overactive thyroid, but infants can have a thyroid gland without thyroid hormone, and this massively affects their cognition, their mental development, can lead to a life of really quite severe mental and physical disability, because in addition to brain development, the thyroid gland is hugely important.
See, it's just gone 10 to, so just letting you know the time.
Thank you. So in addition to mental ability, it hugely affects physical development. Now, if only this could be screened, and if only this could be prevented, but it can be screened, and it can. Now, one of the reasons for not screening is that there's a perception that people who have chronic disease, for example, HIV or AIDS, it carries a stigma. And for us, you'd think, but why would you not screen something that is treatable? But understanding why people don't want the test, understanding how little the test costs, these are important points to make, and these are the points that the authors make. The authors are pediatricians, they're extremely close to this patient. The patient's story is told through their parents, especially the patient's mother, who has a background in healthcare. And bringing this message, a global health message about population screening, the price of screening, the price of long-term, lifelong thyroxine replacement, these are messages that can be brought forward and captured within a patient's story in a much better way than if I was to say, write an essay for me about screening in global health. Where would you begin? Whereas here you begin with a single patient's story. If I just move to the next slide, what is it we want you to look at? Write a factual description of the patient's story. You'll see from the article that you're looking at that there are at least 2 pages of good clinical history. And then take a highlighter pen and highlight the problems that you want to talk about. Now, when you talk about those problems, just list them to start with. And then instead of reviewing them or summarizing them from the literature, really analyze the problem and decide what points you want to make that someone else reading your manuscript would take home with them as a learning point. I'm getting to my last slides now. So really, every assertion that you make in your case report will need to be substantiated. Let me give you an example. If you were to say people in the rural parts of this country do not have access to thyroxine, I need to know how you know that for sure. Because who's reading these manuscripts? Other people who are interested in this problem are reading them. We need to know that that's true. Every assertion needs to be substantiated. We need reliable references and sources of information. Those sources of information won't just be medical databases, and it's so appropriate that this presentation was in the context of library services, because I'm sure the librarians will talk to you about other sources of data, population data, census data, data from outside of the context of randomized controlled trials. And one of the biggest problems in global health is missing data, especially from rural, vulnerable, disenfranchised, marginalized populations, especially in low-income countries where you don't have to go very far outside the center to find out that that's the statistical representation of those populations is woefully inadequate. So I'm on slide 24 now. Please look at our global health case report template. It echoes a lot of what I've said today about how to present information. So much of it is exactly what a clinical case report is, plus that extra discussion, social determinants of health and access to healthcare. And so I'll finish here. Why have a global health case report? Because global health problems are much easier to contextualize within a patient's story. After all, it's the health of an individual. We want to understand their world, and we want to see how those problems are managed within the world itself. So again, global health made local and then made global again. Thank you very much. I'm sorry I overran by 5 minutes, but hopefully I've covered the essentials.